with the other topic of the recent guideline and evolving concept in the septic shock management. They are the Drs. Ankur Bhavsar, who is consultant intensivist and physician at Rajkot, Dr. Viren Shah, he is physician at Anand Zydus, Dr. Chinmay Pathak, he is consultant intensivist at the Baroda. I'd like to request the chairperson, Dr. Ankur Bhavsar, to introduce the speaker of the day.
Yes, good morning everyone. So after a wonderful talk on nutrition, we are heading towards management of sepsis. We have with us Dr. Ankur Bhavsar, who is a senior critical care consultant at Baroda. He is affiliated with Spandan Multi-Speciality Hospital and he is head of critical care there. And he is always a part of almost all academic activities on critical care in Gujarat and even outside Gujarat. He has been a faculty. So I think he is the best person to guide us through this journey of recent guidelines and what are the evolving concepts in management of septic shock.
Thank you very much for Sankalp for generous introduction. Abhishek and Samir and team for inviting me for a talk on septic shock. Now, septic shock is a kind of medical emergency in ICU as we consider myocardial infarction or stroke in any of the hospital. So it is also we have to consider it's a medical emergency. So earlier we intervene, we can have a better outcome. For layman, ઘણી વાર આપણે we are using word septic થઈ ગયું means they already people know this term septic થઈ ગયું, but here difference is infection with organ failure. So that is main consideration when we are treating the sepsis patient. Any infection with organ failure is considered to be sepsis. So previously there was no proper definition of sepsis. In 1992, conference was held by SCCM and ACCP to address the lack of consensus regarding definition of sepsis, and they have given first time definition of sepsis, and it is now known as sepsis 1. So they have given terminology SARS, sepsis, severe sepsis and septic shock. Again after 10 years around in 2001 again societies met together in the ESISM meeting, and they came together and they launched a survival sepsis campaign. The aim of this campaign was to review sepsis guideline periodically and to reduce the mortality by have a uniform guideline for world. So this is the timeline. First time guideline came in 2004, then 8, and recent guideline is in 21. So what I'm going to talk is about guideline which was given in 21. It's really pretty exhaustive, and I know it's 25 minutes, it's not a less time, but it's not very large time also to complete it, but I'll try and cover maximum possible. So changing the definition of sepsis over a period of time. So SARS, sepsis, severe sepsis, septic shock was introduced in 91, and now it is only sepsis and septic shock. So SARS and severe sepsis is being removed from the guideline. So sepsis is current definition of sepsis. Sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. So infection, and our body try to suppress or to treat the sepsis in overwhelming manner with the cytokine release, which may damage further. Suspected clinical criteria: suspected documented infection and acute increase of SOFA score more than 2. And there is one more term they have introduced, Q-SOFA, in 2016 sepsis 3 guideline, in which anybody in the wards also can detect earlier if patient is having GCS less than 15, systolic BP less than 100, or respiratory rate more than 22. So what is a septic shock? Septic shock is defined as subset of sepsis in which underlying circulatory cellular metabolism abnormalities and profound enough to substantially increase the mortality. Clinically, sepsis with persistent hypotension requiring vasopressors to keep mean arterial pressure more than 65 with serum lactate more than 2 in spite of adequate volume resuscitation. So this is the recent sepsis 3 guideline. It has mortality of excess of 40%. So organ dysfunction, we need to we have to have a habit of doing SOFA score on admission of all the ICU patient, and if SOFA score is more than 2 from baseline 0, then probably it indicates that we are dealing with early sepsis. So this is the guideline they have given. If patient is in the ward, or if we want to early screen the patient, Q SOFA score can be considered. If Q SOFA is more than 2, then we can consider patient may be having sepsis. Then if SOFA score is more than 2, then it is confirmed sepsis. And if it is associated with hypotension with more than 2 lactate, we have to treat as a septic shock. So incidence of sepsis overall, this is 2000 data, 17 data, 48 million cases of sepsis out of 11 million sepsis related death occurred. So it is around, roughly we can say around 25 to 30%. In India, as per 2017 data, we have around 11 million cases reported. We don't know about which are the cases which are not reported, and around 2.9 million of deaths. So significant morbidity and mortality is there. So when we are managing the septic shock patient, principal things we have to detect it early. So we have to have a screening tools which detect sepsis and septic shock early, so that we can start immediate resuscitation in the form of fluid resuscitation, giving antibiotic earlier, taking blood cultures, doing a source control, and ancillary management in the sense of ventilatory management, glucose control, DVT prophylaxis. We'll come to that point later. So guidelines have evolved over a period of time. So in 2004, when sepsis bundles were declared first time, so they have included lactate. Of course, we are also doing lactate measurement right now, but they have started with the lactate measurement, blood culture, antibiotic within 3 hours, fluid resuscitation, and the main thing was EGDT, in the sense that there was a target of keeping CVP more than 8, and main target if CVP or mean arterial pressure is not maintained, and SCVO2 measurement also came into picture after reverse guideline, which was published in 2001. So to maintain SCVO2, mixed venous oxygen saturation more than 70, we need to give fluids, we need to give vasopressors, we need to give RBC transfusion. So this was there in 2004. They were divided into 6 hours and 24 hours, and within 24 hours other thing was to keep a glycemic control, low dose steroid, and activated protein C was there. That was there in the guideline in 2004. But later on, after Provesh shock trial, company itself has suggested that probably it is not going to decrease the mortality, and they have removed from the guideline. So 2012, more or less same guideline remains same. Only thing, bundles they have reduced to 3 and 6 hours. And last 2018 guideline have suggested that 6 hours is also 6 hours is too long period for proper management. So we have to start as early as possible, and to complete, and at least we start doing sepsis management and bundles within first hour. So as per 2019 guideline, we have to identify septic shock early, measure lactate level and remeasure after resuscitation, obtain blood cultures, give antibiotic within 1 hour of recognition of septic shock, administer and start fluid resuscitation approximately 30 ml per of kg of crystalloid for hypotension or lactate more than 4. Now this is 2019, they have declared this bundle. As per 21 guideline, lactate should, if more than 2, in that case also we need to start resuscitation, and apply vasopressors if hypotensive during or after fluid resuscitation to keep MAP more than 65. So these guidelines were declared in 2021 after thorough research of many RCTs, meta-analysis, and they have given different kind of statement and grading of evidence. Some of the evidence, some of the statement may not have evidence, but it is considered best practice as per expert opinion. And in this guideline, we have Dr. Yatin Mehta also from India. And this is the, basically these are the, when they have given any statement, it is supported by the evidence, weak recommendation, strong recommendation, against, and this is the quality of evidence. So first and foremost thing, how early recognition of sepsis and septic shock. So we have to have some method in our hospital to identify that a patient is in early sepsis or septic shock and start resuscitation. So there are multiple tools. SIRS, of course, SIRS is removed from the guideline, but at least for screening tools, we can combine this with the other tools like National Early Warning Score, Modified Early Warning Score, Q SOFA. So we have to have some system on the floors or in the ICU from which we can identify. None of this tool as alone is going to is a good method of screening of septic shock. Measuring lactate is also kind of if lactate is more than 2, at least it indicates there is ongoing hypoperfusion. So this it is not very specific for sepsis, but at least if lactate is more than 2, we consider starting resuscitation, and it is a part of 1 hour sepsis bundle. So this is the recommendation. They recommend to using performance improvement program for sepsis, including sepsis screening. Previous statement, they recommend the same thing. They are recommending against the Q SOFA score, and for adults suspected having sepsis, they suggest measuring the lactate. Suggestion means there is a weak evidence. Recommend means that is a strong evidence. So fluid resuscitation in septic shock. So fluid resuscitation is being carried out since years together. First formal trial which suggested benefit of fluid resuscitation was published in 2001 by Rivers et al. And he has proposed that if we keep target of SCVO2 more than 70, it reduces significant mortality and reduces reduction in around 16% of mortality. He has used central venous pressure as well as at that time Precept catheter was available which measures mixed venous oxygen saturation. So targeting that have reduced the mortality. So what we can, the suggestion is that we have to consider giving 30 ml per kg of crystalloid fluid within first 3 hours. Now there are different other trials which they try to replicate the same finding of what Rivers et al. Has done in 2001, and these trials were Process, Arise and Promise, but they could not replicate the same result. So why so? Because now what has happened in last 10 years is that usual care is also improving. Like if patient is coming to our ICU, if patient is in hypotension, we are definitely resuscitating better. So these trials, if we see difference between their control group and intervention group, difference of fluid given was hardly 500 to 700 ml. Second thing, antibiotics are given early, mechanical ventilations are done with low volume strategy. So all this has made improvement in usual care, and that is why the difference between EGDT and usual care was not much, and that is why they could not see demonstrate that all this means in this trial they have not put a mixed venous oxygen saturation catheter, they have not measured it, and still there was not much decrease in mortality. There was not much increase in mortality. So what I mean to say is that it is not required to put a mixed venous oxygen saturation catheter, Precept catheter. We just have proper fluid resuscitation, protocolized management that will reduce the mortality. Now, one thing is we are very sure that too much of fluid also is very harmful. So what we should do, we have to individualize the fluid dose. Instead of giving boluses of 1 to 1.5 liter, we should target giving small boluses of fluid. We can say 4 to 5 ml per kg over 5 to 10 minutes, and then monitor the patient. See whether there is any improvement in clinical parameters, and we have to titrate the fluid management with some kind of dynamic tools. Dynamic tools means we can measure pulse pressure variation, stroke volume variation, but unfortunately all this PPV, SVV is only helpful if patient is mechanically ventilated with paralyzed patients. So if those patients are not paralyzed, then we have one more way to monitor the fluid is passive leg raising. If we do a passive leg raising and if there is increase in cardiac output about 10%, then it indicates that patient is fluid responsive. But for this again we require cardiac output monitor. So in resource limited setting, it is said that what we can do, we can give small boluses of fluid and we see if there is any improvement in blood pressure, urine output, though they are not very sensitive for responsiveness, but that is the one method. One article have suggested that rise in 15% of pulse pressure after PLR after 60 to 90 seconds of PLR may indicate fluid responsiveness. So at least if we can have arterial catheter, and if there is, this is one vague parameter, but if we don't have a cardiac output monitor, then probably this is one way by which we can monitor fluid responsiveness. One more thing, if there is no response, like patient is not responding to fluid therapy, then stop the fluid and start vasopressors early, because larger amount of positive balance is associated with increase in mortality. So as we all know, CVP is not a good tool to measure fluid responsiveness. As we can see here, low, intermediate or high CVP, we have AUC curve is just, it is more or less 50%, while if we are measuring SVV, PPV, we have around 0.9%. So ideal to have some kind of cardiac output monitor, which will, if 10% rise in cardiac output after PLR or SVV 15%, 10 to 15%, then we can say that patient is fluid responsive. Now, how do we monitor fluid resuscitation? So, lactate is one good measure. If we remeasure the lactate serially, if lactate is reducing, then we can say that patient's response is good, because rise in lactate level is associated with increase in mortality. We can see here less than 4 is 1, but more than 8 is around 19%. So, lactate is, if we have blood gas analysis machine, lactate comes with that EBG machine. So, it's not very expensive investigation. Lactate majority time are with the ABG machine, so it is very easy to measure. Still, if we can't measure lactate, then we can use capillary refilling time also. Both are same as per Andromeda shock trial, and so that is why we can measure the capillary refilling time also. So this is their suggestion. So they recommend to start resuscitation immediately. They suggest to give 30 ml per kg of fluid. They suggest to have dynamic measurement for fluid resuscitation, and they suggest we can use capillary refilling time as well as for resuscitation adequateness. Now, what type of fluid? Now, this is not very much controversial, because types of fluid, if we see, crystalloids are always better. It is inexpensive, easily available, and has less renal toxicity. The question comes whether we should use, now there are some evidence that if we use balanced salt solution against normal saline, it improves the mortality, because it can cause, normal saline can cause hyperchloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretions, and AKI. There are few trials which have supported this. Split and salt trial did not show any mortality difference or AKI, but SMART trial did show some difference. What about albumin? So in case if we are, if patient is requiring very large amount of fluid, albumin, they have suggested we can consider giving albumin, though it did not reduce the mortality, but it increases the BP earlier. Lower net fluid balance was there when we used albumin. Of course, there is no role of gelatin and starch right now, and evidence is against using any kind of heta starch or gelatin for fluid resuscitation. So only crystalloid, albumin if required. Now, when we are resuscitating the patient, we should target MAP of 65. Previous guidelines says that we can target MAP of more than 65, but right now evidence is not for the same. Both have similar mortality, and if in case if we target higher BP, more MAP 65, it was associated with higher incidence of atrial fibrillation, but it was associated with lesser incidence of renal replacement therapy. So what we can consider, when patient is known hypertensive, we can target little bit higher systolic pressure, MAP. Now, of course, early admission to ICU definitely is associated with decrease. Delayed admission is associated with decreased sepsis bundle compliance, increased mortality. So as soon as possible after detection of sepsis and septic shock, we should admit patient in the ICU. Now, this is one of the very important aspect, antimicrobial therapy. So we should target giving antimicrobial within 1 hour of recognition of sepsis. But many times it is not very clear, like some patient of pulmonary embolism comes with hypotension, severe tachypnea, and hypoxemia. So sometimes it is difficult to differentiate between sepsis and sepsis mimic and septic shock. So when we are not very clear, we consider giving antibiotic, but continuous re-evaluation required. So after 2-3 hours or 4 hours, we have a definite diagnosis other than sepsis, then we consider stopping antibiotic. But really it is a challenging, and if we are in doubt, we should continue antibiotics. So if we administer antibiotic within 1 hour, within 1 hour of recognition, then it reduces the mortality. But sometimes unnecessary antibiotic is also associated with some ADR like hypersensitivity reaction, AKI, thrombocytopenia, Clostridium difficile infection, antibiotic microbial resistance. So we have to weigh the risk and benefit of giving antibiotic. So this is the guideline they have given. If sepsis is definite or probable and with the shock administered within 1 hour. If sepsis is possible, administer antibiotic with shock within 1 hour. But if shock is not there, then rapid assessment of infectious versus non-infectious is required. And if you consider infection or sepsis, then consider giving within 3 hours. Now, use of procalcitonin. Procalcitonin is a good marker for recognition of sepsis and to give antibiotic. But sometimes procalcitonin alone may not be effective, and we should not rely too much on procalcitonin for the starting of antibiotic, because procalcitonin false positive and false negative results are known. False negative will be there when patient deep-seated infection is there, osteomyelitis is there, or endocarditis is there. And false positives are there when patient is in cardiogenic shock, or patient is in multi-organ failure or trauma. So this patient, pancreatitis, this patient will have false positive PCT. So along with clinical evaluation, we should consider giving antimicrobials. Now they have introduced this term, whether MRSA should be covered when patient is in septic shock. So this all depends on whether patient is high risk for MRSA or not. So we have so many risk factors for MRSA. So each patient we have to individualize the category in which patient is falling, because if patient is not having MRSA and if we give MRSA, that is also associated with harm. And if we are not covering with MRSA and patient is having MRSA, that is also associated with harm. So rapid diagnostic tools like BioFire may help in early detection of the organism and by de-escalation or escalation if required. So MRSA incidence in India is not less. These are the various studies in which around 30 to 40% of staph infections were found to be MRSA, and these are various samples from which 20 to 40% are samples of MRSA. So as per your local flora, ICU flora, and whether it's community acquired or hospital acquired, we should consider giving MRSA coverage. So they are recommending giving MRSA if there is a strong suspicion, and they are against if there is less chances. Similarly, gram-negative coverage, dual gram-negative coverage, we should consider if patient is patient is in ICU for a long time, patient is having multi-drug resistant, ICU flora is having like CRE, carbon-resistant enterobacteriaceae. So in these cases, we should consider giving double coverage for gram-negative infection. Once the culture comes and if we have multiple sensitivity, then we should de-escalate it. Empirical antifungal should be considered in case of patient is in septic shock with all the risk factor like long ICU stay, prolonged antibiotic, neutropenic, immunocompromised, patient on parenteral nutrition therapy, patient is having dialysis catheter. So if all these risk factors are there with shock, with multiple colonization of the multiple sites, then we consider giving empirical antifungals. If not, then we don't encourage to give antifungals. Antivirals, right now there is no recommendation, but if patient is in shock and patient is immunocompromised, then we should consider HSV, CMV, Epstein-Barr, because sometimes with chronic ICU stay or immunocompromised status, this infection can come. And de-escalation and duration of antibiotic, de-escalation is always going to be useful because it reduces the antibiotic resistance, reduces the cost, and reduces the adverse reactions. Shorter duration is as good as longer duration. These are the studies in which they have suggested so many studies with so many infections. Shorter duration and longer duration, there was not much difference. We can use procalcitonin for the stopping of the antibiotic. In starting, when we want to start, PCT may not be helpful, but if we want to stop the antibiotic, PCT with clinical evaluation, it can be very useful. PK/PD consideration, as you all know, all beta-lactams like carbapenems and ceftriaxone, BL/BLI are all beta-lactams in which we give if longer infusion after loading dose, first dose, it reduces the hospital mortality because the drug concentration remain above MIC for a longer period of time, which kills more bacteria. While but in this we have to remember that first dose should be given as a not means not as an infusion but as a bolus that will achieve the higher concentration in the blood. And there are certain conditions like augmented renal clearance, AKI, hypoalbuminemia, and ECMO, in which really there are no clear-cut guidelines how much antibiotic should be given, what doses should be given. For that, we may have to consider therapeutic drug monitoring, because underdosing is associated and overdosing is associated with increased mortality. This is also one very important aspect, source control. Unless we do a source control, like any abscesses, any perforation, peritonitis, empyema, if we don't drain, if we don't remove the infected lines, patient is not going to improve. Just 2-3 minutes more. So vasopressin in septic shock, as of present evidence, norepinephrine is first line. Target MAP of 65. If norepinephrine is not we are not achieving mean BP, then we can consider early adding vasopressin. And if patient is a myocardial dysfunction, we consider adding dobutamine. There is no role of salipressin, angiotensin 2 or telepressin presently. Arterial line is always preferred because we can monitor blood pressure accurately. We can have multiple ABG samples we can take. One more thing is that if we want to start vasopressin early, we can start from the peripheral line as well. Ventilatory management, I think it's not required. I'm not going to detail. Only thing, when we are ventilating with the HNFC or NIV, we should know when to intubate the patient. So we should monitor ROX index, or we should consider monitoring Hecor scale. So when we know when to intubate the patient. And last few things, steroid in septic shock. So this was many years back. Anna has suggested that giving low dose steroid if patient is refractory to fluid and vasopressor, because patient may be having adrenaline insufficiency. So we start giving 50 milligram 6 hourly in refractory septic shock. Additional therapy, at present there is no role of blood purification, polymyxin B or cytokine as per SSC recommendation. Future RBC's targeting is around 7 against the 9. There is no role of IVIG and IgM in septic shock. We consider stress ulcer prophylaxis in patient coagulopathy, shock and chronic liver disease. DVT prophylaxis should be considered because these patients are they have upregulation of pro-coagulant mechanism and down-regulation of anticoagulation. And renal replacement therapy, CRRT, is at present evidence is not that CRRT is better than conventional hemodialysis. And early replacement therapy, if there is no urgent indication, we should not consider. I think that's it.
Hello. So thank you, Ankur Bhai, for this covering this broad topic into such a short period of time and quite elaborative topic. So because we have just over time thing, we can take 1 or 2 questions. Any relevant questions, 1 or 2? If public, yeah. So.
Right now, as per surveying sepsis guideline, and we do not have much evidence that Sepsivac helps in sepsis or septic shock. At present, we do not have enough evidence. Yeah, that's what we mentioned. IV corticosteroid should be considered when patient is still hypotensive after adequate fluid resuscitation and after vasopressors. Within 4 to 5 hours, if there is no response, then we can consider 50 milligram hydrocortisone 6 hourly.
Okay, so no more questions. Thank you. Thank you, Ankur Bhai.